Yo, what's going on? My name is Nate Brody, and welcome to the show. I don't know if you guys are hearing me. All right, yeah, this is good. All right, there we go. So there was like a little delay. So what's going on to the Magic Segment Show? My name is Nate Brody, and today we talk healthcare. I'm here with my comrades, Xavier down here. He is AKA Mr. Universal Healthcare. Comrade, tell him your name, comrade, and where you're from and what you do.
So I'm Xavier. I am down here with Drag. I am what people would consider a democratic socialist in the United States. I support the Bernie iteration of Medicare for all, although I could be swayed to the Jayapal one of the faster transition.
Yeah, you got to tell you got to describe what those two things are to us,
Well, so they're pretty.
Well, not now, but I was just thinking eventually. Yeah. All right, so
that's me.
So I just want to say, thank you, comrade, and Das Vidanya. You know what I'm saying? Das Vidanya, baby. Okay, now we're going from the democratic socialist scum, as Trump will call you, no disrespect, to my man Brandon. Brandon, tell me, capitalism lives in America, right? Brandon, what are you here for?
I don't really think capitalism does live in America, but I do advocate for a capitalist solution to a lot of these problems that we have, like anything where we're trying to distribute resources to where they are most highly valued. I'm in favor of capitalism.
That's right.
And that applies to healthcare, obviously.
And it's okay, USA, baby. That's the way it's done in the grand old USA. Now, let me introduce to you our Canadian on the panel. Now, he's also a capitalist guy. He hates universal health care. He's coming to America. Mr. Hogtie Champ, please introduce him.
I am as right wing and conservative as they come in Canada. So,
it's an important caveat.
Yeah, well, a lot of the viewers of Magic Sandwich will have a rough, will know who I am and have a rough idea of what I used to do for a living. Regardless what my education was, I decided to dedicate it to sort of more focus on health policy, including comparison of how healthcare systems are funded in different countries. Mm-hmm. And of course, being here, there's a big weight on comparing Canada and US because they're the same people, generally speaking, typology, but they fund very differently. So it gives you a great crucible for evaluating the differences, the benefits and costs of funding healthcare one way or another.
All right. Well, hey, we're all here to have a conversation, and let's get to it. Now, I'm going to throw it to Xavier first because Xavier is one who's advocating for the change of the healthcare system. Obviously, our current healthcare system is one that's kind of based on some capitalist principles. More or less, if you can't pay, you will fucking die. So, Xavier, what do you think about the current system, and what changes do you think would be best made to the system?
So I think that the system is fundamentally broken at just the level that we have right now. We have, I think the number is 32.2 million people are uninsured.
Wow.
Or underinsured, which means you have the obviously uninsured, but the underinsured, it means that even though they have healthcare, the healthcare that they have does not actually provide for their healthcare needs. So we have that major deficit in the system, and I think that human lives are worth more than that. And also that if we have a population with universal healthcare, it means that we have a healthier population, which means that people are not going out of work for treatable causes. People aren't going to the emergency room instead of primary care doctors, which is a huge problem in the US. And that's basic start off.
No, you gave us a lot to work with. I'm going to throw it to you, Brandon. What about the current system would you like to keep? And do you think there are any changes? Because Brandon's talking about a wholesale overhaul of the system. What's your take on it?
So what would I like to keep?
What's your theory? Would you like to keep? Would you like to change? Or if you like everything to go as the same, spell it out.
Right. I think there's a lot wrong with the United States healthcare system, namely regulation, price controls. I just think that the government doesn't really contribute a whole lot of value. I think that one of the things that is really difficult to articulate is how do we overcome the price barrier to access to care? Because I think when we talk about healthcare, everybody thinks that price is the biggest barrier to access. And so when you hear about universal health care, it seems to solve what is perceived to be the biggest barrier to access, which is price. Because you go to the hospital and your bill comes out to be $0. It sounds great if that's the way you're perceiving the industry, if that's what you think the biggest problem is. So in economics, though, price plays a very fundamental role in the distribution of resources. It signals the economy not only how we should modulate our consumption of resources, but also signals the economy to generate resources in the quantities that are being demanded. So if we impose price controls on healthcare or really any resource, then we're not going to be signaling the economy, and resources are not going to be generated in appropriate quantities, and people are going to consume more than they need to.
Well, Brandon, you know what? I'll ask you this question. What would you consider, or is there an example of which you consider to be a good healthcare system? Because obviously no one's will be perfect, but if you can pick a country or give an example of what you consider to be an effective healthcare system.
Well, I don't know of one currently that I really like,
or something close to what you would be striving.
Well, I
for.
mean, in the United States, in the early 20th century, we had a much less regulated industry, and healthcare costs were maybe 4 or 5% of income on average. And I mean, today we spend like an equivalent amount or more than that on entertainment. Also, the amount that we pay on housing is a lot. I mean, we have a lot more square space of living space than our European counterparts. So, I mean, if we could have maintained the price index for healthcare since the early 20th century, which we haven't, then I don't think that the prices we're talking about with healthcare would be out of reach for the vast majority of individuals.
Now, I got to push to my man Hogtie Chip, because when you're talking money, this guy makes sense. So Hogtie, he's talking about what it seems like a price side economic model. Obviously manipulating prices because the government has the price caps and those type of things. So, you know, do you agree with that, or is it a more supply side economic model? Because right now, Brandon is arguing for a release of, a relaxation of the price controls that are now on healthcare.
Well, there's one aspect of his approach to it that I think he's starting in the right place, and then you'll see very quickly I think he's kind of gone off the rails. And that is to apply economics to healthcare economics. Right. A lot of people seem to think that there's economics for a whole bunch of different problems in communities and states and nations, but they don't want to apply it to healthcare because they sort of want to say, well, we want to be a good people. We want to help people. We don't want people starving. We don't want people with broken legs not being treated. So a phrase I would often hear was, you can't put a dollar value on a human life. And you absolutely can. You absolutely do. And you certainly must. So I don't mind applying economic principles. I guess where I was I actually jotted down some notes, because you'd use the term price plays a fundamental role in the distribution of resources. A great point. Now, I guess I'm trying to understand it. You're saying that it seemed to me like you're expressing the fear of the under-generation of resources. That is, that the demand would outstrip the available resources because of the government limiting the prices. If the government says that you can charge whatever you want for some product and the average price in the market is $1,000, but then the government comes in one day and says, well, no, we're going to limit it to $100. Well, those people that are making $1,000 per unit are not well motivated to continue producing, right? So I understand that. But I guess what I'd have to ask Brandon is what is your goal here? You want to, I guess, you want to make sure that this isn't too expensive for people, for individuals, for families. You want to make sure that it's not too expensive for governments, because ultimately that's where people's money go. And I'd expect you want to make sure that this is a profitable venture for hospitals, physicians, nurses, basically everybody involved in the delivery of healthcare. Does that sound like a right way to look at it? Which is,
Brandon, you're muted.
Unmuted, but
unmute you. So
sorry about that.
Follow-up.
Yeah.
If that captures your position properly, I have a quick follow-up. So go ahead.
I would say for the most part, but can you just repeat the part about the government? I didn't quite catch that.
Well, I think that if you became the emperor of the United States, and you could just, without worrying about politics, you could just say, this is how we're doing it from now on. You would want to design your healthcare system so that the doctors are making money, the hospitals are making money. People wouldn't shy away from producing this resource. When you refer to resources, you're talking about the physicians having time. There being machines, MRI machines. There being people who know how to put casts on broken legs. And you want those people to make money, right? You don't want them to be impoverished like the way. Okay, good. And you don't want that to come at the expense of families. You don't want that to come at the expense of corporations. Bet you sure don't want it to be at the expense of governments, right?
Well, yeah. I mean, I think the more we reduce government spending on most things, then that's better.
Yeah. Well, what I would say, if those are your goals, this is going to, grind your gears a little bit. But if you want doctors to make more money, they make more money when there's a single payer system. If you want hospitals to make more money, they make more money in a single payer system. If you want governments to spend less money, that is the money they collect through taxes, the governments spend less money in a single payer system. If you want families to pay less money, either through things they have to pay when they get the services or through their taxes to fund the system, families pay less money in a single payer healthcare system. So that's my initial reaction to your opening comments, is that if those are your goals, laudable goals, well stated, but all of those goals are better achieved through a single payer system, which I will set the proof of that to the moment so the other guys have a chance to talk. But I hope you're slightly surprised by that point.
Let me bring in Xavier real quick for this point. Xavier, we're talking about prices in the single player system, and you mentioned in your little opening how it seemed that the Bernie's system seemed to be a little bit more cost effective. Can you explain why you believe that?
So, what we see in the American healthcare system is that people have it's the highest source of bankruptcy in the economy for the American system, with I think 62% of bankruptcies in the study that I saw were caused by healthcare, which means that you're causing a deficit in the economy in that aspect because people are going bankrupt. That means their credit scores are being hit, which means that they're getting less loans into the economy, which hinders that aspect. People are with these problems. They don't want to go and seek healthcare because they don't want to take on those debts. So they wait until the last minute and go into the emergency room instead of seeing their primary care doctor, which costs the taxpayers more in the end. And when you get into a single payer system, the single payer is the one that's doing the prices instead of private insurances. Each private insurance debate or negotiates prices separately. So you could have one private insurance paying one price and then another private insurance paying a much higher price. Whereas with a single payer, you have one set price for the region. And with Barney's plan, there's not really a set national price. It could be on the state level that prices are set so that you don't have one national thing, which will cause hospitals to close down everything. So
before I ship it to Brandon, I want to throw it back to you and Hogtie Champ, because I think you guys are making a very important point. But I don't want to lose it in the wind. You guys seem to me to be arguing for price controls, and you guys know I was about to say a socialist system, the capitalist system, price controls are thought to be a negative thing. For instance, if the government said you could only spend $2 for milk and everybody can spend $2 for milk, we understand that there's some negative consequences. That model doesn't work. It didn't work in, that's the reason why the Soviet Union, went bankrupt. That's the reason why Cuba has its problems. That model doesn't work. So is that what you guys are arguing for, price controls, but in the system, in the healthcare system?
Not me.
No, I know you're not. I'm saying that's what Xavier and Hogtie Champ.
Well, I mean,
price controls. Go ahead.
Well, I mean, so in the universal system that Bernie's proposing, it's not a price control. It's that the government is the buyer of the source. So it's saying here's what we're going to pay you on this rate for this. And if you have no choice in what that rate is, then it's a price control.
Like if I can't go there. I can maybe negotiate with the government, but I can't like I can go to some other place and you know what I mean. It's a price control.
So I mean, it is a price control in that sense, but it's not. So it's going to be done with the aid of economists, and it's going to be set at a price that keeps the market intact. It's not going to be set at such a price that it forces the market out, because then there's no point in the universal healthcare if there is no healthcare.
Now let me throw it to Brandon, because Brandon seemed to want to jump in there. So Brandon, what do you want to say about the price controls? Because obviously I was pushing back on their model. So go ahead, explain.
In economics, there's a fundamental problem of knowledge, and no single actor has all of the information that they need in order to allocate the resources to where they are valued. I recently got a book series for my kids called The Twaddle Twins, and it teaches a lot about philosophy of government and all this stuff, and economics in a way that kids can understand. And one of the best books is called The Miraculous Pencil. And one of the surprising things that this book talks about is the fact that there is no one single person who knows how to make a pencil, because there are so many things that go into making the eraser, the wood, the lead or graphite, a little metal piece. I mean, no single person knows how to make this. Price is the signal that the computer that we call the economy uses in order to allocate these resources, despite our lack of knowledge, omniscience. And so we could talk about how we're going to make really good decisions about the prices and everything and all this, but ultimately you are working with less information than you would if you allowed a cost coordinated system to function.
So Hogtie,
or price coordinated, price
yeah.
coordinated.
So Hogtie, you've heard the argument. What do you think?
It gets very little traction with me, and I'll tell you why. Well, first off, to answer the first question you asked, price control might be a point of focus, but I want to be clear, and I think Xavier did a great job making this clear. It's not an issue of saying, well, what we need to do is do price control. We need the government to say things like, well, cars are too expensive, so we're going to cap the price of cars at $300. Right? Everybody gets a Hummer for $300. You can't charge more than that. I mean, that's craziness. The price control emerges by virtue of, as Xavier said quite correctly and eloquently, that it comes about because you have a single payer system. That single payer can't just decide this is how much we're going to pay for something, right? So you take, for example, the Ontario Ministry of Health and Long-Term Care. They have they'll buy vaccines at 8 million units at a time, right? So they then are able to pay, well, whatever they're paying for that divided by 8 million, right? There's a price control by virtue of the fact that they bought 8 million of a thing and then they made it available to the people. Now, if they said, well, we want to buy 8 million units and we want to pay $1 for them, each unit, well, then they're not going to be able to buy them. It's still negotiated in an open market when the province of Ontario or the province of Saskatchewan, any of these single payer systems want to get MRI machines or machines for breast cancer screening or like say buy millions of vaccines, they still have to negotiate in an open market to get those things. The difference is, and I think Xavier made a really good point, I'll be quick about this, is about the bankruptcies. The difference is you don't have hospitals that go unpaid. You don't have doctors that go unpaid. You don't have a whole system that is designed to chase people down to get them to pay their medical bills, because the doctors and the hospitals aren't getting paid for a quarter of their patients. And these families are going bankrupt. You don't have that happen in a single payer system. So it's not just price setting just because that's what we want to pay. Those things are still negotiated and they get good prices for them, which is why people in single payer systems actually pay less through themselves and through the government. And there's fewer bankruptcies, and we don't have this whole industry of trying to bankrupt people because they can't pay their bills.
Oh, that's the government now. It wants their money. So, go ahead, Brandon, now you want to jump in there.
Yeah, so you're talking about bankruptcies and how a single payer system avoids that. So we would expect that the nations with the greatest single payer systems to have fewer bankruptcies, right? Now, do you see the United States as having a predominantly single payer system, or Canada? Probably Canada. That's what we hear about all the time, right? Well, Canada's rate of bankruptcy is actually higher than the United States, according to the Fraser Institute.
Mm.
So I don't think that this argument about bankruptcies really reflects what's happening in our respective economies. Now, I'm not advocating that the United States has a great system because I don't believe that at all. But I don't think the bankruptcy argument really carries a lot of weight because I don't think that that's reflected in reality.
Well, Xavier.
Now,
Oh, I'm sorry. Just on that point, because I'm assuming Xavier is going to have something to say because you made the point about the bankruptcy. Xavier, he's made, I think, a very excellent point. He says that, hey, even though most of the bankruptcies here in the United States may be done to healthcare, but now you're just shifting the problem someplace else because Canada has more of a bankruptcy problem than the United States. How do you square that circle?
So I cannot square that circle because I did not research that information prior to. So I cannot make an informed opinion on that. But that could be from multiple issues. There's multiple issues that go on with bankruptcy. It's just the fact that the U.S. bankruptcies majority come from healthcare problems. So I don't know how to fix the Canadian bankruptcy problem, but a clear fix for the U.S. bankruptcy problem is universal healthcare.
No, Brandon, you said you had another point, right? So Brandon had another point.
That's not actually. It's actually non-medical expenditures, which comprise the majority of debt among bankrupt consumers in the United States and in Canada, in fact. So it's not. I don't think it's being portrayed accurately. But now Hogtie was talking about how there has to be some kind of a negotiation. Now,
yeah, and a single payer.
That assumes negotiating power. And when you have a single payer, it seems to me that the single payer has all the power because they say you take our prices or you don't get anything. You don't get any of the business. So how in the world is that a negotiation rather than a price control by another name?
Well, Hogtie, I think he's more or less making the monopoly argument. If you have one buyer and one payer, then he's right. If you don't buy, then they don't get paid. They have eight. They're still going to make the $8 million, but now who they're going to sell it to because the one person who's going to buy them can't make it. So, is it a monopolistic type price control? Because in other words, Brandon, I think, is making another good point. It's price control by another name. Hogtie.
Well, we're sort of a little bit sideways there because generally when you talk about monopoly, you're talking about there being a single vendor, a single supplier, and many, many demanders. In this case, there's one demander, right? And that is, and the example I used was the province of Ontario. And when you're buying 8 million things, you do get a lot of power in setting that price. But if you have to buy these vaccines from a private corporation that has to make money and they can't do it at the price that you say we want, then they just don't offer that as a product. There are lots of pharmaceutical products that just, you can't buy them at that low. EpiPens is a good example. You can't buy them at a cheap price. Not the EpiPen auto injector. The epinephrine itself isn't that expensive, but the EpiPen auto injector is an expensive thing to make. And if they want to charge $105 as a retail price because they can't make money for charging less than that, well, then that's what's going to happen. And so it's still a negotiation because you have multiple suppliers. Often it's only 2 or 3 suppliers, and then you have one purchaser for these things. That's not a monopoly.
I still think it is a monopoly, but I do recognize that single payer systems, they do require the producers to justify their prices. But one of the problems is the single payer system does not respect this idea of profits at all. And so it's usually that's what it comes down to. You can recover your costs, but I don't know about these profits though. I mean, it seems a little excessive. And it's the profits and the profit motive that signals the economy to generate more resources. And so if you have that single payer system and that's the point of negotiation, the profit margin that you're allowed to make, what seems in a species sense reasonable to the single payer, if that's below the value that the producer or other producers would place on that work, they're not going to produce.
Well, Xavier, what do you think? In a healthcare system,
can I respond to the profit thing real quick?
All right, go ahead.
The idea that the single payer system, and this is part of the socialism hysteria, right? That they somehow that when you have a single payer system, that means, we don't want profits, comrade. Like that's just not how that works, right? You want to know who makes money in a single payer system. The drug producers, the people who produce the MRI machines, the people who know how to run the MRI machines, nurses, doctors, people who mop up puke for a living. All these people make tons of money. We're happy to have private clinics. If you're a physician and you open your own private clinic, or you go into a partnership with other physicians, you're going to make scads of money. You're going to run it like any other business, and these provincial healthcare systems are quite happy with them. So both the service providers are there on a profit incentive, and they do quite well, thank you very much, and the people that the government's purchasing from, the vaccine manufacturers, the machine manufacturers, they're quite happy to have them make lots of money. The difference is in a system that isn't a single payer system, who makes the money? And the answer is the insurers. You have for-profit insurance. You're sitting here arguing, saying that what Xavier's pitching here is a way of removing profit from the people who work hard to keep us all healthy. In a single-payer system, all those people make scads of money. What you're arguing for, Brandon, is I want to preserve the right of insurance companies to make grand profits. That's what you're here arguing for.
Yeah, I do believe that.
I do, but first, before I get back to Brandon, because I know you want to respond to that. Let me get back to Xavier, because we've been talking about Xavier's plans, but we really don't have the fine details of the plan. So Xavier, do you think the plan that Bernie, or that the two plans that you alluded to earlier, how would they solve the problems that are being brought up by Brandon and some of the intricacies by Hogtie?
I mean, it would so pretty much covers everything that Hogtie said of costs or the money would increase for hospitals and other things, because people wouldn't be declaring bankruptcy on that. They would be getting a clear line of income, so they wouldn't have to be troubled over, are we going to get this person's money? Are we going to get that person's money? They know that they have a steady source of income, so hospitals can actually plan better. And then hospitals also will not be negotiating with multiple private insurances, having to cover different filing procedures and different other sources of administrative costs that come with other private insurances inside the system. So, I mean, you're saving money for the hospital just through that administrative cost by itself.
So Brandon, it seems like, well, from what Hogtie's saying and from Xavier saying, it's saying that you're getting everything that you're saying that you want a system that's low on cost, efficient. It seems like the universal healthcare cost system that they're putting forward kind of gives you all that. So what are you arguing for in counterpoint?
Well, the point is not cost alone. The point is not price alone. The point is distributing resources to where they're valued. So when you talk about prices and costs being lower or lower per capita or whatever, does that reflect efficiency, or does that reflect an inability of the system to provide or to supply resources in the quantities being demanded? I think that's a question that's very much overlooked. One example is we had a hurricane a few years ago when I lived up in Pennsylvania and I worked in New Jersey, and I always had to cross the bridge to get back to Pennsylvania when I'd go home at night. And I did not realize this one day, but the fuel supply had been disrupted by this hurricane, and I had arrived at work that day on fumes. So I ended up waiting in line at the gas station, just hoping and praying that I could get home, that I could make it home. And the reason is that the governor of New Jersey imposed price controls. And yeah, the gas was cheaper. It was really great if you were first in line. But for me, it wasn't so great, because, hey, I would have definitely paid more for gasoline on that particular day because I just wanted to get home. Meanwhile, this other guy over here had a giant generator that he wanted to fill up so that he could just keep his lights on that night. And I just wanted to get home at all. But because of the price controls, I was unable to outbid this individual who honestly probably valued that fuel less than I did in that moment, given the market conditions at that moment. So just because things are cheaper doesn't mean that you're doing a better job distributing resources. And I also don't buy that
So
things are cheaper either. Now, Xavier,
Well, hold on.
he's
Let's
okay.
do this.
Right.
Let me just take this one point and throw it to Xavier and Hogtie and see what they respond. Go ahead, Xavier.
Well, I mean, price gouging laws are completely irrelevant to this because price gouging is there specifically for emergency situations such as that. And that's for the sake that you may be able to pay more in gas prices, but you have a struggling family who can't afford a $500 emergency in the time of a natural disaster. They won't be able to keep on increasing their price that they're willing to pay for gas. During a major crisis, everybody needs those resources to survive. If you just do, hey, we're going to do this giant price, then people will not be able to afford stuff. So that's completely irrelevant in my mind.
I don't think so.
Well, good. Well, first, Brandon, let me get Hogtie champion because he's been waiting for a while, and then I'll let you respond.
Sure.
Go ahead, Hogtie.
Actually, I'm going to yield on this one because my attention drifted for a moment because I want to look into the bankruptcy of Brandon's bankruptcy. So we'll come back to it, I hope.
All right, go ahead, Brandon. You can respond. I'm sorry.
All right. So what happens with price controls when in an emergency situation like the gasoline situation I just described? What happens is that the price goes way up. So the gas station says, oh, we can make a lot of profit right now. So they raise these prices. That might sound like you're just taking advantage of people who are in need. But let's set that motive aside. That might be true. The result, and remember, no individual actor is aware of this at the time. This is what's called the invisible hand of the economy, of the free market. Okay. The result is that people who value the resource more than other individuals are able to outbid those individuals who value that resource less. And then the profit margins, they signal other producers elsewhere in the economy who are looking over here and saying, oh man, we can make some nice profit over here. So they rush resources over there to that market where they're most needed. Thomas Sowell has written many books about this. One of the best books is Basic Economics, and he gives many examples where price controls prolonged the crisis. Whereas if you let them gouge, there are examples where there were no price controls. People were allowed to gouge the market, and the crisis was not as enduring at all. It passed very quickly. And the reason is because producers were able to very quickly and incentivized to very quickly move their resources to where they were needed. It's like a gold rush.
Well, and this is just for clarification from my point. You've explained how producers can then move resources into a situation to fulfill that hole. More or less, you're making a supply and demand argument. Since supply is low, demand is going to raise the price, and then now people, the companies are going to revert resources to that to take advantage of those high prices, bringing prices down again. But in the situation that you were talking about, an emergency situation, that's the problem. You've made the assumption that there's a supply chain there that can backfill that price, but that's not what was happening with you. The supply chain was cut. That's what forced the prices to raise. So, in other words, to keep prices stable, that was an effect because the market couldn't work because you couldn't get supply in. So prices were kind of artificially raised because of the disaster. No,
I'm
sorry.
no.
Go ahead.
Yeah. I mean, it's a good question. The supply was disrupted, right? But it's only the normal supply chain for that area. What happens is that the higher prices would have made it more valuable for suppliers in other areas who normally don't bother to supply where I was located. Mm-hmm. It makes it more valuable for them to just go ahead and maybe go a little farther to supply fuel where I was at. So if the supply is disrupted over here, the high prices signal other producers and incentivize them to maybe go a little out of their usual comfort zone to bring resources to me where I need them. And so that's how prices work. They serve a very important function. And I think when you're manipulating them artificially, you're definitely going to have some unintended consequences like shortages. In places where you have drug shortages, you also find price controls. Medicare did not used to have price controls on prescription drugs, and as soon as they imposed price controls, the shortages went from the number of drugs in shortage it was in the tens, and after that it was 200 and something. Right after they implemented price controls, so you could see cause and effect. I mean, it's among economists, it's not controversial at all that when you manipulate price, you disrupt supply.
Well, let me kick it to Xavier. Go ahead.
So I find this this sidetrack completely irrelevant, because in the market you have things like insulin and other things that price dramatically increased in the U.S., didn't dramatically increase anywhere else in the world, and the supply stayed stable. There was no deficit in supply. It's just the price increased. You can drive across to Mexico. You can drive across to Canada and get it much cheaper. And if you're inside the U.S., it's much higher. It's not because there's a price control. It's because drug companies and other things have had patents on it for 25 years, I think, or some crazy number that they have a patent on it. And there's no generic competition that can come on the American healthcare market because it's profit driven and because people can lobby Washington for that. But yeah, that's besides the point. But there's no price control in that sort of way.
Yeah, because it seems like what you're saying, Brandon, isn't playing out in the actual marketplace, because Brandon has made a very excellent point. And the places where you do have these price controls, if you want to call them that, the prices are lower and there's really no disruption in supply chain. And the place where you don't have price controls, prices can be 4 to 5 times more. So, and the supply is the same for both situations. So how do you now square that circle?
I'm pretty sure that Xavier just said that we have higher prices in America, but we have the same supply.
That's correct. Yeah, that's what he said.
So we don't have a shortage.
No.
So high prices, you don't have a shortage. Whereas in Canada, you have low prices, and you look up drug shortages in Canada, you find articles about drug shortages. When Trump just talked about, sending or allowing Americans to purchase drugs in Canada, I mean, you can look it up. There are articles complaining about that because they're saying it's going to exacerbate our drug shortages. I mean, it's not me saying it. It's not me saying it. It's Canadians saying it.
Well, we have.
What do they have? They have price controls.
We have our learned Canadian friend HTC. So what happens? Can you not get your aspirin? Or is the cocaine shortage up there?
There had been an EpiPen shortage. Actually, it's funny why I went to that example. There actually had been an EpiPen shortage, and there was what's another one? It's an antispasmodic Buscopan. There was a shortage there. There are these intermittent shortages, and don't be surprised by this. When there's a drug shortage in Canada of a specific product like epinephrine auto injectors or Buscopan, as it happened about a year ago, the same shortage happens in the U.S. It's a supply side problem. If there's a factory that burns down somewhere and they're the ones who make a certain binder that helps this pill be made, and then the manufacturers don't have that product, then everybody suffers a shortage. It's not an economic issue. That's a do issue. Again, I do hope we cycle back to the bankruptcy thing, by the way.
All right, we'll go back.
It's become a really popular thing going back a number of years for Americans to hear these amazing stories about this bizarre land of Canada. It might as well be Narnia, the way you guys talk about it. The story about how there's only one MRI machine in all of the province of Ontario. Ontario, the province that is the biggest by population, the biggest geographically, has only one MRI machine. And there are 40% of the Americans who believe that's true. Right? I mean, this is anybody who makes a claim like that is just somebody who's not interested in having their beliefs comport with reality. So we don't have shortages like what the Americans are saying. We do have, obviously we want more doctors, we want more specialists and that sort of thing, but that's true everywhere. But the whole the waiting list, people die on waiting lists and we have death panels, it's all nonsense.
Well, Brandon, you know, it seems to be overblown, the shortage, the critical drug shortages in Canada. So let's try to understand this from a different perspective then. If one of your goals, because one of the goals that you brought forward was price, and not just price, but the overall reduction in cost of the system. Now, from what I've been seeing, even the conservative think tanks say if the United States moved to a single payer system, it would be cheaper and everyone will be covered. Is that not attractive to you, to Brandon?
So I gotta correct you.
I'm sorry. Go ahead, Xavier. No, sure. Correct me. You guys are the ones.
So the information on whether it's cheaper or more costly are in between. It could be as much as 1.2 trillion less, or it could be as much as 2 trillion over.
All right, because everything I've seen is said it's be equal or less, but I haven't seen anything that said over. But
so when we're factoring in total healthcare costs.
Okay.
So we may save on one part,
Mhm.
but it may cost us in another part that isn't accounted for with the healthcare program, such as making more hospitals, doing other things.
Well, this is a great question to you. Then, with that type of uncertainty, there could be an extra $2 trillion. Then why try to change the system? Because that's a hell of a gamble.
So we'll go back to one of my original points.
Go ahead.
I value human life more than I value profits or costs, and our country doesn't have a problem with expanding costs for things. It's just where we want to expand costs, because we've just increased our military budget over the next 10 years by 700 billion.
So Brandon, Xavier's made a great point. We got the money. We got it for guns. We got it for tax cuts. Why can't we spend it for healthcare?
Well, spending money isn't the only problem. You could spend a lot of money and get poorer results. I mean, just look at spending on education in the United States. I mean, it's absolutely skyrocketed. And most of that is on administrative expenses, incidentally. And what has happened to our education results? It's flat. And yet we're paying so much more money. So you can't just say, let's just throw money at the situation and it will surely get better. You have to understand what is driving these results. And when we're talking about the allocation of resources, there's no better system to allocate those resources than a price coordinated system. We just don't have the information. We don't telling bureaucrats to allocate resources is like saying that a Pentium 3 processor from like 15 years ago is going to run better and be able to process more information than AMD's new Ryzen processor. You just have fewer transistors.
Well, hold on. Before we get into the transistors, I do want to ask a question about the bankruptcy to Hogtie, because Hogtie, you brought it back up. Now, from what I'm seeing from the numbers, because I do like a quick little Google search, it seems to me that there are more American bankruptcies for healthcare than there are total bankruptcies in Canada altogether. So, am I wrong with that, or is that Hogtie?
You're doing it by rates. Okay, well, there's going to be a moment when I say this that the audience will quite rightly, you should jump on my case about this. What's the fallacy? Genetic fallacy. Okay. So I just, while we were discussing it, I admitted my attention was distracted. I actually read 5 different sources, and all 4 of them say what you just said, Nate, that the rate per thousand, rate per 100,000, whatever you want to base it on, of bankruptcies is much higher in the U.S. There have been marked increases in the rates of bankruptcy in Canada, but there are some sort of Canada economy specific issues that I could present. But I guess what I'm saying here is, there's one source. 4 of the sources say what you're saying, Nate. The other source is the Fraser Institute, which the Fraser Institute, which is very famous for being super conservative and doing a lot of apples and chickens comparisons. they're saying what Brandon said, but if you go and you look at their paper, which is widely available, you can tell that they're comparing. Okay, let me say this. You got to remember, insolvency is a broader category than bankruptcy, right?
Yes.
In Canada, you can do consumer proposals, which is slightly different than a bankruptcy. It's still a form of insolvency. But so we have bankruptcy and we have consumer proposal. At the time that the Fraser Institute's looking at this data, it was after the either 2000 or 2007 or 2008 revision to American law that made consumer bankruptcy much, much, much more difficult. Remember, you can't just say, like if Nate here wanted to stand up and say, I'm going to declare bankruptcy thing sounds pretty cool. He can't just charge off and declare he's bankrupt, right? They look into these things and they say, do you meet the criteria for insolvency protection, right? And it's your nation's laws that would govern whether he would be able to declare bankruptcy. Whereas if I wanted to declare bankruptcy, I would have to, thread the needle, fit the brackets, the sort of the boundaries of what we consider insolvency here in Canada. The Americans tightened up their insolvency, their bankruptcy rules. And wow, the bankruptcy rate went down because it was harder and harder and harder for people to get bankruptcy. So there's actually been an increase in people just living burdened with crushing debt. While there's been a decrease in American bankruptcies, there's been an increase in American families that are being crushed by their debt. And now you want to talk about, it's funny, is the idea about, well, the bankruptcy sources. How many Americans go bankrupt? Let's not focus on people like who, lived in Fort McMurray when the fire burned down Fort McMurray and those people couldn't earn money anymore, right? That's one type of bankruptcy. Let's compare the bankruptcies due to this particular issue. And that's what Nate just asked. How many people in the States are going bankrupt because they can't afford to pay their medical bills? How many people in the States are crushed financially for the rest of their lives because of their medical bills and their inability to meet the criteria to go for bankruptcy? It's a whole bunch. How many Canadians go bankrupt because they can't pay their medical bills?
All of them.
All of them.
Well,
so let me even though it was a little spicy, let me throw Xavier in here just real quick because Xavier seemed like he wanted to throw something, and then I'm going to go right back to Brandon. So Xavier, do you want to add on anything?
Oh no.
All right. Go ahead, Brandon, because I know you're going to need a little time to respond because he gave you a lot. So go ahead. Let's hear what you got to say.
Yeah, I'll be happy to review any of those sources. But the point I think we can agree on is let's reduce bankruptcies. Let's make things more affordable. And in the United States, we absolutely have a price problem. The prices are exorbitant. And now, when did this start? This all started, I believe, around 1965 after we passed Medicare. And ever since we introduced our own single-payer system, the prices of healthcare on the whole have outpaced inflation.
Well,
no, it started in the 80s.
Well, just to be clear, I have a degree in economics. I have a BA in economics.
Really?
Yeah, just to go back. The reason why prices are what they are in the United States it's a weird phenomenon. It's with the insurance companies under President Nixon. President Nixon, when he signed the health insurance law, what that did is that the health insurance companies had to negotiate with hospitals about how much they were going to pay, and there was like this listing of what the prices were going to be. So the hospital would say, for instance, a surgery would cost $100, but the insurance company said we're only going to pay you $10 because they were negotiating. So what the hospitals and drug companies did was raise the price to, let's say, okay, $1,000. So it was called anchoring. It was the anchoring problem. So you would anchor at $1,000. So when you negotiate down to $100, and that's when you get that price. That's why in the medical field they always say, all these things are so it costs so much in the United States, but it's not the actual cost of the service. It's because they're inflating the price because of this negotiation tactic between the provider and the insurance company. It's a big problem. It's a well-known problem within the market, and that's one of the problems with the prices that you were talking about earlier, is that the prices are artificially high for these services based on this particular problem of anchoring between the provider and the insurance company. I probably explained that very poorly, but that's the issue.
I'll have to look into that issue. I believe it. I'm not super familiar with the issue of anchoring, but I think there are a lot of problems, a lot of cost drivers that are causing the out of control prices in American healthcare. And I mean, one of those things is, I believe, our own universal healthcare system. I mean, it was projected to cost one thing, and it ended up actually costing like 7 times more what it was originally projected to cost. And you can see in I have a chart here. I don't know if I'm able to screen share or not, but
Sure.
it shows. I mean, the inflation, it goes kind of in a steady line, but then healthcare goes whoop, like a very hockey stick line. And that all starts in 1965 when we introduced our own system, our own single payer health care system. But that's not the only cause either. It's also the fact that we use health insurance more like prepaid health care. Insurance should be for low probability, high price health events. It should not be for high probability, low price health events. Like I got the flu, so I'm going to go to the doctor. That's not what insurance is supposed to be. And so you're getting very little value out of your insurance company being the third party payer there, when you could just pay out of pocket for that. And they're introducing expenses, which makes sense when you're talking about high price, low probability events like a heart attack, but they make absolutely no sense and add absolutely no value when you're talking about just going to the doctor because you got a cold. So there's an extra cost there by using insurance in places where it doesn't suit the business model.
Hold tight.
So there are a lot of drivers.
Yeah, there's a couple of points I got to ask for clarification here. I mean, first, I think I'm going to say, Brandon, you're 100% right about the costs being different, being very, very high in the U.S. I mean, there's the service providers and the manufacturers in the U.S. Really now have driven up a very high expectation of how much they ought to be paid for something. I'll tell you this: if you know, because I'm raving about Ontario, for example, and I said, if you guys went and said, hey, what's Ontario doing? They're doing okay healthcare wise. You set aside the lie that there's only one MRI machine, stuff like that. You actually look in front, they're actually doing quite well. Let's just take that system and we're going to import it to the U.S. One of the first things that would happen is that the service providers and the manufacturers would say, you're paying us what now? Because they would be earning less on a price per unit thing. In part, it's because of what Nate was saying about the anchoring thing. So this is going to be one of the very, very difficult challenges. You will not be able to fit another country's system onto your system because of that expansion, that inflation of prices. You're going to have to sort of in a stepwise way get control over some of these problems, like how much money the insurance companies make and bankruptcy rates. The one thing I'm really straining to ask you about is you twice in this last bit here you mentioned, I want to mention the insurance thing. You're talking about high probability low cost events, right? So for example, I want to have auto insurance to deal with the situation if I hit a deer and do $9,000 damage to my truck, right? I don't want to have insurance to deal with paying for oil changes, right? And pay an insurance company to collect money from me so that they can pay for my oil changes, right? I want to self-fund. I want to self-insure my oil changes and my tire replacement, right? And you're thinking of things like, well, we really shouldn't insure people for things like going to the doctor because you have a sore throat or your child has an ear infection. Here's the thing, an emergency room visit for your child's ear infection is going to cost about $200 in Canada. It won't cost you $200, it'll cost the system $200, which of course, some of that eventually comes out of your pocket based on progressive taxation. Nobody wants to think that this stuff is free. You're well aware of this. I'm not explaining. I know you know this. Nobody wants to think that this stuff is free. But that emergency room visit because, oh, my kid's got a really painful ear infection is going to cost the system about $200. In the US, that same visit is going to cost about $400. Now, you want to refer to that as a high probability, low cost event? Have you got $400 on you right now?
No, I don't have $400. I have $40 in my primary care doctor. There's a movement of doctors called direct primary care, and they have taken the perspective that I'm talking about, where we should get that third party payer out of the picture because it contributes no value to these low cost, high probability events. And so my doctor is part of that movement. You pay $50 the first visit, and once you're a customer, it's $40 anytime you have a visit. And It's an amount that I can definitely afford whenever I get
You're
sick.
answering a different
But
question what I asked. Your answer, by the way, a 10-minute appointment with a physician here, $27.60. So it's $40. It's $50 for you, and then it gets discounted to $40 because
you're
of this system that you're talking about. Here it's $20, $27.60. Actually, that figure is from the schedule fees a number of years ago. But when I go to see a doctor,
you were comparing it to an emergency room visit.
No. I was talking about emergency room visits. You then started talking about the $40, $50 visit to your physician, right?
Right.
So the emergency room visit is $200/$400. The doctor's visit is $27/$50 or perhaps $40. So it's still more. Now, you might not think $40 or $50 is a lot of money, but you need to look around your country and see how many people, it might not be $400 isn't that much for you. Maybe you've got $50, I don't know. But there are a lot of people that the idea of taking their child to a physician or to an emergency room, like I think Xavier made this point earlier on. I have a question for you. I don't want to forget, but Xavier made this point earlier on that there are families who will not take their kid to he used term about fewer ER visits for primary care events, right? So an ear infection would be a primary care event. You don't want to go to the emergency room for that. But if your family is so much struggling, as so many millions and millions, hundreds, tens of millions of Americans are in a situation where taking their kid to a doctor for $40 or $50 is a choice they have to make. They have to give up something for that. So they'll wait it out and it'll get worse and worse. And instead they'll go to an emergency room because there's a law that says the emergency rooms have to see you even if you can't afford it. So now instead of going and paying $40 for something that would be good for their kid, they wait until it gets much worse and now it's more expensive to treat, and they go to an emergency room and somebody else has to pay the $400 and then try to collect that $400 from this family that couldn't find the $40 for that. In my case, my kid gets an ear infection. I take him to a doctor. It costs the government the $27. I'm going to let Xavier in on this.
Yeah.
But Nate, the question I want to ask, so I don't want to
Well,
misunderstand.
hold on. Let's pass to Xavier. Go ahead, Xavier.
So $400, I don't know where you're going to the emergency room, because the last time I went to the emergency room, the bill that I got, so I had to go to the emergency room while I was in Colorado, outside the military base, because somebody decided to hit me with a beer bottle inside of a bar. So I went to the emergency room. I got the bill, which then I passed on to TRICARE, but the bill for the emergency room visit and just for them to put some gauze on my head, they didn't have to do stitches or anything, was around $3,000.
Okay, I can answer that. I can answer that real quick, and then I do want to get back. There's a question I want to ask Brandon, so that he's not misunderstood. So one thing you got to remember is that in Canada, there's not a single payer for the whole country, right? I mean, each province has its own system. Each territory has a system. The federal government has a system for the military and diplomatic services, and a system for for inmates of federal institutions, prisons, and hospitals. And when you go from province to province, there's a little bit of up and down difference in the price. In the US, all of the prices are higher, and the variability in the prices is also higher. So maybe what happened to you in Colorado is fine. Now, you're asking where I got the $400 figure from. That's sort of an aggregate average. You got to keep in mind, too, that that's total cost. When I say that it costs $200 to see for a single emergency room visit in Canada, that doesn't come out of your pocket. That's how much comes out of your pocket plus the system. In this case, it's $0 out of your pocket, $200 from the single payer. And the US, you do have to pay a bill, but remember your emergency rooms are government subsidized. So they might give you a bill for $216 or $308, but that whatever it costs to go to an emergency room in your state, those total costs are covered between you and the government. Well, that's a good clarification. Can I ask Brandon the question just so we don't get
go ahead. Yeah, definitely.
Yeah. Brandon, you mentioned a couple times about the introduction of a single payer system in your country, and I'm curious what you mean by that. That actually generally baffled me. Where in your country was there a single payer system introduced?
Medicare, Medicaid.
Yeah, those are not single payer systems.
Medicare, Medicare is a single payer system.
They're not able to negotiate prices for the most part.
No, the problem. Okay, let me.
That doesn't mean it's not single payer.
I'm going to suggest, Nate. This is an important clarification that has to be made. What a single payer system is. So in Canada, we have a thing. It's the Canada Health Act that says. Remember, just constitutionally, healthcare is in the This is the separation of powers, right? The provinces are in control of healthcare. They're the ones who license doctors. They're the ones who license nurses. Each province has its own ethics regulation, things like that. So healthcare workers are done provincially. The federal government can't just say, this is how we're going to do healthcare from now on. The Canada Health Act sets up basically a buy-in program. If your province wants to do a single-payer system, then your province will benefit from transfer payments from the federal government. If one day the province of Saskatchewan, I picked that one because Saskatchewan's the most socialist province we have here, but if one day they said, no, forget it, we're getting out of the single-payer system business, they would be allowed to do that, but they would no longer benefit from the federal transfer payments for healthcare. Obviously, all the provinces buy into it, so that may be a bit of an academic point. But when your province has a single payer system, literally, when you have a service, there must be literally a single payer. So if I go to the doctor and that doctor says, well, look, I can talk to you about your problem, but I got to charge somebody $27.60. I'll say, no problem. I'll pull out $27.60 out of my pocket and give it to you. That's not legal. If your province has legislated a single payer system for the people in that province, there may be only one payer for all of the services. For the listed services. It doesn't mean that everything is free. In your province, you might still have to pay for some prescription drugs and so on. But when we say a single payer system, we're saying literally it's not legal. We have a payer. So we have a provincial health insurance plan, and that is the payer. If I go to my doctor, that's the only person allowed to pay for it. I can't get my mom to pay for my visits, right? The payer, the doctor is allowed to charge only the system. Now, in the United States, if you have Medicare, Medicaid, any of that stuff, well, then obviously you're going to send the bill off to them, or they're going to take care of the bill in some way. If you don't have that, well, that's fine too. The doctor's still going to see you, and someone's still going to have to pay that $40 or $50 that the doctor's going to want for that 10-minute visit. If there's no law that says the doctor can't charge you or charge your mom or somebody else.
Yeah, definitely. Well, I think it's not I do want to just kind of, because it's kind of a little gray area when the single payer system for Medicare, particularly because it's kind of driven by age. After you get to a certain age, then it kind of becomes this almost quasi single payer system in the sense of when you reach the age, then it doesn't pay for everything.
No, hold on. You're mixing up the notion of a publicly owned health insurance program.
That's true. Yes. You're right. Yeah. Because yes.
It's a public option without it being a real option. You just get rolled into it at 65.
Yeah, because it's triggered by age, so it's almost like because Social Security is the same thing. But it's interesting. But I'm giving Brandon charity.
It's a massive government program which corresponds to the price of healthcare outpacing inflation in America.
Hold on. Can somebody look up Medicaid too? Because I don't think Medicare started in 65, right? Wasn't that one of the Great Depression things with Social Security Act? No, I thought it was like in the 30s. But anyway, so Brandon, if you want to share your screen, if you look on your screen where it's a screen share, because you said you had a graph that you want.
Oh, I see it. I see the button. Yeah,
I hit the screen share button. Oh, go ahead. If you wanted to share the screen, because I was interested in the graph.
Yeah, I don't have pulled up right now, but I'll keep that in mind.
Forget about it. All right, so let's move on to the next point of contention. Because we've dealt with price, we've dealt with price controls, and we've dealt with the inequities in the system. But now, for Brandon, Xavier has made it very clear what his ultimate goal for a system is, and that goal was that everyone, more or less, he's saying healthcare is a human right. Right, Xavier, or am I simplifying it too much? He's saying healthcare is a human right, and the cost itself should justify itself because everyone should have the right to get healthcare. Or do you agree with Xavier that healthcare is a human right? And if not, why not?
Okay, so when people ask if healthcare is a quote right, what they're really asking is, do you think everybody should have?
I think
nobody would say
yes.
I think nobody would say no. I don't want everybody to have access to healthcare. But there's a second question wrapped up in that: should we have government provide that healthcare? And to that question, I would say I don't really think that they're particularly good at providing that healthcare. So now, in the sense of whether it is a right or not. I don't think that anybody has the right to the labor of another individual, or we can compel the labor of another individual. So in that sense, I don't think it's a right. But the important question is, do I want everybody to have access to health care? And I do want that. I just don't think that price is the only barrier to access, nor even the most important barrier. In fact, I think when you think of price as the most significant barrier to access, you actually end up with unintended consequences like shortages. So I think actually supply is a more important barrier to access of healthcare than the price.
Well, I'm like, so access is just a buzzword that's trying to obfuscate the point, because it's not access, because we could have 100% access, but insurance costs $1 million. Everybody has access to it. It's just, do they have money? But what I am saying is that every person should have healthcare. It's not access to it; it's have it right then and there.
Well, the Canadian government was sued back in the 2000s by George Zeliotis. I don't know how in the world you say that last name, but he was actually sued. No, he actually sued the Canadian government because he was guaranteed healthcare under the single-payer system, but he didn't have access to healthcare because of the shortages, because of wait times, because of constantly having to reschedule his visits and procedures. And the Supreme Court, she said, the Madam Chief Justice Beverly McLaughlin, she stated, access to a waiting list is not access to healthcare. So just because you have a single payer system where you don't have to pay anything, at least at the point of access, that doesn't mean that you have access to healthcare. That doesn't mean you can get healthcare services. So I think I have a real hard time when we deny that there are other barriers to accessing healthcare other than price. Go ahead, I think it's a crucially important point.
So as of 2016, Canada had better or quicker access to a doctor and nurse when they needed care.
Well, they're also moving more towards privatizing.
Not Canada. So I looked at the chart the other way around.
Oh, okay.
Canada had worse. Sweden had worse, but Germany, France, United Kingdom, Australia, Netherlands, and like comparable country average was like 6% higher than the U.S.
So just to clarify, you're saying that there are countries that have universal health care that beat the United States in access to health care.
So either systems that have a single payer or a single health industry. So
now we do have our resident Canadian here, Dr. Canadian. So what do you say about that? I think Brandon's making a very interesting point. Is that you've had the court case, you've had this, you've had that. What do you say about this?
Well, it's funny because I about 2 minutes ago I wanted to open my mic to say, Brandon, move over because I got to sit beside you for this one because you're 100% right about something. The idea that healthcare is a right, is a fundamental human right, is nonsense. That's not how that works. We should, oh my goodness, I don't want to take us too far down this trail, but just in brief, I'll say that rights are not something that fall from the sky. Rights are something that are created by legislation or by contractual accords. So to say that you have a right to something, well, what do you have a right to? You have a right to whatever the other party in that agreement says. So your country, through the First Amendment, has said, look, we're not allowed to make laws that impair your freedom of religious belief or your freedom of speech. Our laws through the Constitution Act at sections 1 and 2 have the same effect. The government's not allowed to make laws to impair those things. So under that legislation, yes, we have the freedom of religion, we have freedom of speech, but the idea that, well, geez, it'd be really good if people had health care, well, then therefore that's a right. Do people have a right to food? Do your groceries show up at your house because some government worker comes and delivers it to you? No. The rights are created by the laws, and nobody's guaranteed food. Right now, there ways you can help people with that stuff, but that's a separate issue. Now, where it went a little crazy is the idea that is Brandon, you actually made the claim partway through that about this thing, your disdain for benefiting from somebody else's labor without paying them for them. Did you vote? When's the last time you voted, Brandon? How much did it cost you to pay the people who were standing there to help you place your vote and to count your vote? How much did you pay out of pocket for that? You're allowed to vote. How much did you pay the members of the military who fought, got maimed, died for your right to vote? Zero. You don't pay for any of that stuff out of pocket. You're quite happy to benefit from the people who make the roads. How much do you pay your fire department? If you got a fire going on, how much do you pay?
A lot of those are volunteers.
Victim of a crime. I'm not even done yet. Have you ever been a victim of a crime? How much do you tip the police officer? He gives you a bill for what, $400, and you get tipped
taxes. And police officers take 15 minutes to show up. So I think a private solution would be better in that case as well.
Complain. You do.
Argue.
Individuals should have their own private police department.
Octai, you're taking us off point.
I'm getting back to the last point that I wasn't able to address. Sorry, what was the most recent point about access? Again, apples, comparing apples to potatoes here. There are some access problems that are related to geography. I had a very serious broken leg when I was 13 years old, and it happened in a place where, guess what? Nobody knows how to fix that. So I had to be driven 4 hours to the nearest city where somebody knew how to fix that. That's not an access problem. You mentioned the George Zeliotis case, which
driving is not an access problem.
What's that?
Driving is not an access problem.
You don't know where I'm from, buddy. You can't have doctors every six miles, right? If you're in a community that's got 300 people in it, they're not all they're not all orthopedic surgeons, right?
So you have a doctor shortage. So you had to drive really far.
Is that what you're doing?
Medical care?
If I'm in a place that has only 300 people, you're saying that somebody's making a mistake because not one of those 300 people is an orthopedic surgeon. So that community of 300 people has to have an orthopedic surgeon, a cardiologist, an oncologist, an OBGYN. All these communities have to have all these different, and they have to have their own MRI machine. We have access problems by the nature of geography, right? If you're in the Yukon, you might not be able to see a cardiologist in a week. That's got nothing to do with the funding. In fact, the funding makes it possible for people in remote communities to see cardiologists and to get breast cancer screening. If you live in North Bay, Ontario, good luck getting some breast cancer screening. Oh, wait, there'll be a truck that drives up there with a portable 2-view radio mammography machine. And for free, the women in those remote communities can get breast cancer screening because that's the way we fund those things. So the access problems you're talking about, it's a real apples and potatoes comparison, because where people report these problems is more related to geography, not to a shortage or anything like that, or government bureaucrats not knowing what they're doing. I notice you're quite happy having your government bureaucrats run the fire department, police department, military, paving roads, all that stuff. George Zeliotis, by the way, George Zeliotis's claim is because he did have a right to healthcare. But his right to healthcare comes by virtue of the fact that we created healthcare legislation. And under that legislation, he ought to have received service, right? Not just merely put onto a waiting list. He ought to have received service. And if there was no healthcare funding available to people, when George Zeliotis stood up and went through all the court system right up to the Supreme Court of Canada and said, well, I should get healthcare. If there was no law saying that, well, somebody should pay for his healthcare, then he'd be wrong. He doesn't have a right to healthcare. He has a right to healthcare because he lives in a jurisdiction where healthcare is part of what is created in legislation, right? That's why he has a right to it. I'm not saying he had a right to it because he's a human being. He has a right to it because he was a Canadian living in a jurisdiction where the access to healthcare is guaranteed by legislation. By the way, just a quick note, George Zeliotis' wife is very, very ill, and they're going through this again, by the way, because his wife is also not getting very good care. But what I'm saying is, when you complain about a George Zeliotis case, keep in mind the reason he has a proper legal claim to healthcare is because we've agreed that people should have healthcare, and we've added that to our legislation.
You haven't really.
Hold on, Brendan. Just one thing with Hawkeye. I agree with most of the things that you're saying, but I just want to make just one quick point. that is the point you're making is for any right. For instance, the freedom of the press. You don't have that if you go to Saudi Arabia, right? So all those rights are always enshrined in some type of legislation. Just Brandon, we're going to come to you in 1 second. Let me just go to Xavier so he can just get the point, and then I'm going to give you a lot of mic time to respond. Go ahead, Xavier.
Clear some. So in Sanders' bill and Jayapal's bill.
Okay.
Healthcare is put into law as a right.
Okay, yeah, and that's generally how it's done. So go ahead, Brandon.
So I believe it was the Zeliotis. How do you say that? Zeliotis? In that case, the reason he was suing is because he wanted to pay for private health care, and he wasn't allowed to. It was outlawed. So because he was suing because of the failure of the single-payer system to provide him with access to health care. And it was also by law making it illegal for him to make the choice to pay for private care. So it's not the case that in the single-payer system, we want everybody to have health care. I mean, it is actually illegal to pursue health care when the single-payer system fails because of the shortages.
You're right about that. I want to address it really quickly. What you've done though, Brandon, and I'm telling you, you're right about this example. But here's the thing: is that if you want to talk about Zeliotis for any length of time, you found a needle in a haystack. No system works perfectly, and so what you end up having is you have a system like how driver's licenses are issued, for example, and they say, well, you need a photo card, you need the signature card, and whatever else, and then you get some people coming along and saying, oh, it's part of our religious belief that we don't have our photos taken. I said, well, the traffic safety law doesn't permit that. So these people are guaranteed freedom of religion, which means they should decline to have their photos taken for their photo ID. But we have traffic safety laws that says everybody needs photo ID. So there's now a disharmony in the law. So how do we solve that? Somebody's got to sue somebody. Best of all, they sue the government. So we made the system as I described earlier, and I do think you have some traction on the notion, Brandon, but it was the idea that we're going to have a single payer. And again, Medicare and Medicaid, those things are not single payer systems. Doctors are allowed to collect money from who they want. Under the Canada Health Act, Zeliotis' province bought into the notion we're going to have a single payer. When a doctor provides service to Mr. Zeliotis, the only party that's allowed to pay for it is his province's health insurance plan. But he wasn't able to get that access. And he said, well, that's fine. I should be able to pay somebody. I should be able to go to another country and have them pay for it or something. I should have another option. And there were no other options under the law. So you have a law that says that people have a right to access healthcare, and you have an individual who's not getting access to healthcare. So what's the solution for this needle in a haystack problem? Mr. Zeliotis sued the government and lost and appealed it all the way to the Supreme Court of Canada. And that's where it won. And that now propagates downward to now we got to say, well, now we have to revise the system to accommodate for these exceptional cases. By the way, the truly sad part about it is that now Zeliotis is in the same situation again because his wife is not getting timely access as well. But I mean, if you've got a country, 39 million people can access the healthcare system, and you can go through and find many needles in this very, very large haystack. Is that how you want to address whether or not a single payer system is good for the people of your nation?
I don't think that it's a needle in a haystack. Let's see here. I'm looking for specific information here. This is a little bit old, but
hold on. Let me do this.
Over.
You're a haystack hunter.
Hold on. But Brandon,
yep.
Do your research. I'm gonna throw it to Xavier to see what his feelings are about this. So Xavier, okay. What do you think?
Well, I'm like, so for the U.S., if we had that law as a right that you have to get health care,
that's a right.
Yeah, there would be tons of lawsuits of lack of access in the United States. So I grew up in very rural Pennsylvania.
I'm from Pennsylvania.
Yeah, so I grew up in a town called Ashland. So there was a hospital there.
Ashland.
Oh. Yeah.
My bad.
So there was a hospital there, but if you had anything more than like a sprained ankle, you would literally have to drive an hour away to an actual good hospital. So like when I came down with flus or like bad flus or stuff, that because that like there's no real healthcare system there. So you had to drive an hour away to get to a hospital for broken legs, broken arm, anything that you had a problem with, you had to go an hour away. So I mean, could somebody sue there for lack of access? Probably, because the hospital just wasn't good. It just didn't have any resources because it was a very small community. Nobody really had healthcare to pay, so there was a high rate of medical bankruptcies in the area, and there still is. It's one of the worst in Pennsylvania for that.
Well, let me do this. Let me. I want to try to narrow the objection, because it seems like, Brandon, it seems like Hogtie and Xavier's objection to your examples are that you're pulling out unique examples that's not indicative of the overall picture. You know, you found the black swan in the sea of white swans. So how are you now equating this one example, this what Hogtie said is an exceptional example, to the overall picture? Because if it is an anomaly, then obviously it's not indicative of the overall model.
Yeah, it's important that you're speaking about representative examples. I'm speaking generally about the way that prices work in an economy, and we can point to before and after examples where, when we impose price controls, that the access to care, access to medicine decreases. I gave the example of Medicare. They didn't used to have price controls, now they do. And so the number of shortages for medicine shot up. I believe I gave another example as well. Well, let's talk about Canada for a second. Over a 15-year period, you're saying I'm misrepresenting Canada, but over a 15-year period, the average wait time between a referral from a primary care doctor to a specialist was 9. It went from 9 weeks to 18 weeks over a 15-year period.
Hold on, Brandon.
Yep.
Even though without this point, I do want to drag it back just one step to you moved on from price. Now, from my understanding, price is an effect of two conditions: the supply condition and the demand condition, right? You have supply and demand, and the way those two operate, that gives you a price, right? And it's that graph. But now you would agree that demand for healthcare is universal. We all the demand for healthcare. Now there may be some ups and downs based on flu season or whatever, but everyone is going. The demand for healthcare is pretty much going to be flat across the board. It's going to be high, but it's going to be flat. So we're really talking about a supply side solution, right? We're not talking about some on the demand side. We're talking about the supply side solution. So when you're talking about price, right, and we know that the only thing that we can actually really change in the system is the supply side of this. Why are you? It seems like your rendition is assuming the supplies are going to stay the same, and assuming that there's nothing that we can fix on the supply side of the equation to affect cost, because that seems to be what everyone else is saying. If we fund the supply side to meet demand, then price should take care of itself. But how are you? It seems like you're skipping the supply side analysis and just saying these are price controls. How are you getting there? How are you getting to the price controls?
Well, when you tell medical providers what they can't charge. The Bernie Sanders plan, which I believe Xavier said he was in favor of, some people argue that it results in cost savings of $2 trillion or something like that. If you look at the plan, it imposes a 40% reduction in reimbursement rates for medical professionals. Those medical professionals are not going to stick around. The high cost of going to medical school and licensure is not going to seem worthwhile to doctors. Do you think that's not going to result in a shortage? Do you think that's not going to result in people losing access to care? I mean, doctors, I think it's about a third of doctors in the United States will accept Medicare. So our Medicare consumers have a very difficult time finding doctors, and the doctors that do accept Medicare, they only accept a limited number of patients.
All right, I got two hot hands down here.
Oh,
So I'm
really?
gonna go to Hogtie first, and
Yeah.
then Xavier. Go
And this
ahead.
will be quick. You just said that only about a third of them accept Medicare. So those doctors who don't accept Medicare, are they being paid by somebody else?
Sure, but Medicare, when you're on Medicare,
Oh.
Medicare pays for it.
I want you to ponder the concept, just even the phrasing, single payer system. You now
Within
announce,
Medicare.
well, these there are some doctors who take money from Medicare and some doctors take money from the other payers.
Yeah.
That's not a single payer system.
Okay, the what you want to call it, I'm not even going to argue over the words. The fact is that
No,
when we
no, no, no. I'm
introduced
not letting you get away with
when
that.
we
That's not words.
when we introduced Medicare,
Concepts are very different.
Yeah.
if you're on Medicare, Medicare pays for it.
Yes, what he's just saying is that in a single payer system, everybody has to take
If you're-
the
if
single
you're on
payer. Yeah,
We're just working
So
with
that's
different
the thing.
definitions.
I understand. Go ahead, Boo. Let's be charitable. Go ahead, Xavier.
But okay. So I'm like, there's seems to be a clear discrepancy in the way I'm looking at it and the way you're looking at it, of that, like the profit motives of people going into it. The research, so Bernie's plan that he put out a thing of 2016 when he was running for the presidential bid of, hey, these are going to take into effect, but in the actual Senate bill that he put in, there are no actual, here's what's going to be paid, here's what's not going to be paid. They set up the Medicare payments right now as what Medicare is doing right now as the initial thing of what may occur, but it's most like the prices are going to most likely, or the payments are most likely going to increase to somewhere between what Medicare is paying and what private insurance bottom line is paying.
Yeah, but just to step in just real quick, but Brandon's making the argument that those price controls are going to drive out suppliers because you won't have the doctors, you won't have, because they're going to be making less money. If they make less money, you won't, it's inevitably going to have a higher price because there's just going to be less people to give you the supply, and by there being less supply, then you know what I'm saying, it just is not going to work because that's going to have the access effect. There's not enough supply, not enough access, so now prices could be low, but nobody can get healthcare. So that's the argument Brandon seems to be making.
But like I stated earlier, the prices that are going to be done in conjunction with economists in the area to figure out what the market value is that can be paid with keeping the service available while keeping the costs low. So it's not just going to be like, this is the price, you have to pay it. If you don't pay it, then get out of the system.
Here's the problem with trying to use bureaucrats and recruiting economists to work for the government is the responsiveness of those prices to the market conditions. I mean, if we have to convene a council every time we want to assess prices, I mean, it's going to be very unresponsive, and you're going to have a lot of the same problems.
I'm like, prices are already very unresponsive because you have multiple health insurance companies dealing prices. You have one company dealing here, one company dealing here, one company dealing here, and then they have to come back to the drawing board if some new technology comes out. A new MRI machine comes out and the hospital wants to put it in. The prices change. It's like,
well, I don't think that means they're unresponsive. I think it means they're responsive.
No, because you have multiple people saying different prices at different points. Nobody knows what the actual value of the product is because you have multiple people are negotiating separately.
So you think, let me ask a clarifying question. Do you think that an MRI machine has one correct price, and it's just a question of how to get at that one correct price that an MRI machine across the board should cost?
No, I think there's a range of the price for the area and how much usage it's going to have versus how much it costs the hospital to buy.
Okay, so, but you were complaining that there were different prices for the same thing in different places.
No, I'm saying that in the same region, with the same usage, with the same price of the machine, multiple insurance companies are paying different negotiated prices for the same thing.
Oh, okay. Okay.
So instead of you walking into Walmart and being like, all right, this thing's worth this amount that Walmart's charging, Walmart is instead being, oh, this person is this, we're going to charge him this price because we think we can get that from him. Because that's the anchoring that Nate was talking about of able to charge more because nobody knows what the others are paying.
Yeah, well, I mean, and again, one of the problems is it comes again to price. A lot of people don't know what the price is when they access medical care. Then until they get the bill at the end or whatever, they have no clue. And so there's a lack of price transparency. So again, it comes down to removing information from the economy that's causing these discrepancies. I guess that's my point for right now.
You know what? We have about 10 minutes left. So I'm going to look to the audience for any questions to see if anybody is going to befuddle us with any questions. I see Jesus is Lord. Jesus is Lord says, I am now an atheist and praise Satan. Thank you, Jesus is Lord, for your recommendation. And
his proper name is Lucifer.
Thank you. Thank you. Thank you, Jill. Jesus is Lord. That was his contribution for tonight. Okay. Lucifer Almighty. Lucifer Almighty. Okay. So I'm looking through the chat. Doesn't seem like there's any questions. If you guys have any questions, just tag the Magic Sandwich Show or AKA Nate Brody, and I will get to it. All right. So I'm going to throw a quick question to the audience. Okay, so Xavier was talking about his particular plan, and he has two plans. You said you like the Bernie plan better. Do you think that you could convince Brandon that the Bernie plan is better than a purely economic plan, a pure economic plan that's based on Darwinian economics?
Darwinian.
That's only the strong survive, right?
I mean, I guess I would go with drug prices. Or drug shortages. So for the U.S., one of the it's a medicine for heart surgery, heparin, or I think that's what it's called. So there used to be a bunch of companies that used to make it, or there used to be companies that make it, but as more companies were able to make it, as the patent ran out for it and more companies came in, other companies stopped making it, and that's what caused a major shortage in the market because only Pfizer makes it now, with Teva being the other last thing, but they've stopped production on it. So, I mean, if we're in a pure market economy, if there's no more profit for multiple companies to make a drug, they're just not going to make it, and you're going to be left with one supplier who can't match needs.
Well, hold on. Let me run back to the chat because now the questions are coming in hot and heavy. First, from Exiled. Exiled says, Nate, you are the best. Thank you. Please go subscribe. Thank you, Exiled. But that's not her question. That's just what I said. Her question is, have we discussed or taken into account medical malpractice insurance? And how would that change the game? I'm going to first go to Brandon, then I'll go to Hogtie. So Brandon, medical malpractice. How does that equate to your particular piece?
Yeah, that's a topic. I don't know a whole lot about malpractice. I mean, it makes sense that if there's frivolous malpractice suits, then it would raise the prices of healthcare. But as to the particulars, I'm not really sure. I do think that patients should have an ability to receive compensation for negligence or malpractice, but what the market actually looks like right now, I'm not super familiar with those arguments, so I'll probably have to hand that off a little bit.
I'm going to ask Xavier, what does he think about the medical malpractice? Then we'll ask Hogtie about how it works in Canada. So go ahead, Xavier.
I defer to Hogtie. I do not know enough information to make any statement on this one way or the other.
All right, Hogtie. So how's the medical malpractice issue handled in Canada?
Well, I mean, this is really tidy because it's the same between doctors in Canada, doctors in the U.S. It's the same between doctors and lawyers, doctors and who else gets it? Optometrists and surveyors and just like any profession. One of the conditions of licensure, if you're part of a self-governing profession, you say, what would they be? Doctors, lawyers, optometrists, dentists, pharmacists, surveyors. There's a whole group of them. One of the conditions of licensure to be a member of one of these self-governing professional associations is that you have to have proper errors and omissions insurance. And they have to pay for it. So, for example, there is no single payer system for lawyers. There's no single payer system for surveyors. There's no single payer system for dentists or optometrists or pharmacists. And if you want to go into practice in any of those fields, you need to figure out how you're going to fund your premiums. Now, a lot of these organizations do sort of bulk purchase. So if you're a member of the College of Physicians and Surgeons for Minnesota or Saskatchewan, they often arrange for a standard product that would apply to all of them. But this is, I'm a little confused by Exile's question, because I would say, you asked the question, like, how is that addressed? If you want to go into those fields, well, then you find out what the premium is and you pay that premium, just like everybody else who needs insurance. I'm unclear on how the issue of medical malpractice insurance in someone's mind sort of affects the choice of how things ought to be paid for, because in Canada, we have a single payer system for medicine, but not for lawyers.
Well, but let me explain it in Wisconsin. I believe it's Wisconsin, but don't hold me to it. What happens is that medical malpractice, there was never a cap on how much someone who sued can get for medical malpractice. So if doctors were having $1 million payouts because juries were awarding patients millions and millions of dollars. So what happens is that people would stop covering things like OBGYN, for instance, because they would say that it would the risk associated with such heavy monetary damages, then insurers just wouldn't come and cover it. So without the coverage, then you couldn't practice. So it directly affected the supply of doctors because you couldn't be insured to pay. So what the state did was put an artificial cap on the amount of money that people could actually win in these type of litigations. So the cap was like $100,000. But if someone got really injured, let's say, that needed a $2 million settlement, then what would happen is the state would then come and backfill that money. So that's what I believe she's talking about, the effect of medical malpractice insurance to supply when it comes to doctors. But let me move to another question. It says, I understand, it says Magic Sandwich Show, I understand it to be one of the highest expenses for physicians. I believe we're still talking about
So Drag said to pick a question and then he'll bring it up on
see, he just brought up this question. So he brought up Exile. All right, so next question is from Peter Wentz, and he says, Nate Brody, and again, subscribe to the Magic Sandwich Show. I'm glad you guys found my channel and stalked me out and subscribe, but this is the channel I want you to subscribe to. Hit that red little buzzer bell there. Subscribe, like, share, do all that great YouTube stuff. You know how we do. So it's saying also, if a religion has an alternative view on healthcare, should they be allowed to deny coverage for their children in a single payer system? So I'm going to ask the single payer advocates that. This goes to both Hogtie and Xavier.
I'm like, so somebody could not take their kids in to get treatment, but they'll have coverage. So I'm like, and then they'll probably be charged with murder of their child later on. So that's
all right. What about you, Hogtie?
That's a flat no. You cannot in a single payer system. It depends how you frame. I shouldn't say you can't. It would depend how the lawyers write the legislation. Right, the doctors don't write the legislation; they're consulted. But I will say under any province or territory that runs a single payer system in compliance with the mandate of the Canada Health Act, the answer to that question, Peter, is a flat no. We have this discussion once in a while. Oh, we're gonna make a helmet law for motorcycle riders. So, well, don't make a helmet law. Let people choose not to wear helmets if they don't want to. It's freedom. But if they get into an accident, we're not paying for their health care. No. That's not how that works. Smokers shouldn't get healthcare insurance. Come on. No. That's not how it works. Under our single payer system, I mean, go ahead. If you guys can engineer a way, some legislation that's sensible in that way, and it fits the sort of cultural traditions in your country, then go ahead and give it a go. But I'm telling you, Peter, in our country, that's just a non-starter, that issue, especially denying coverage for children. Oh, and by the way, to clarify that too, that this idea about families having alternate views on healthcare, and then now you ask about their children, you as a grown-up can deny obvious healthcare things. You don't want to go to a doctor to set a broken bone. You don't have to. But under separate legislation related to minimum standards of care for parenting of children, what you're suggesting, the idea that somebody could say, well, I'm not taking my kid in for appendicitis surgery, that's not an arbitrary example if you read the news from Calgary. And you don't take your kids for appendicitis surgery, well, you don't get to have those kids anymore. They take them away.
Interesting. This question is from Crimson 60620. That is his phone number. I know you, Crimson. The Magic Sandwich Show. Does Brandon think that bureaucrats in government are different that the bureaucrats, the private sector? So I'm thinking he's saying, do you believe the bureaucrats in the government are that much different than the bureaucrats in the private sector? Because again, you're still talking about death panels, except one is paid by the government and one is paid by a corporation.
Well, I'm glad you acknowledge the existence of death panels. But this is an excellent question. And years ago, before I ever really touched the issue of healthcare, I was very much into economics, but not so much on that topic of healthcare. That was a question that kind of was confusing to me because somebody said, well, you have death panels on private healthcare too. Right? The bureaucrats in the private sector and the bureaucrats in the government sector are very similar in some ways. The main way is that they both are interested in controlling costs. Now, this is, I think, a point for my side that I would like to make. Bureaucrats in the government also want to control costs. A lot of times the private industry is criticized for restricting care on the basis of cost. Well, that's exactly what the government does too. They have algorithms and formulas that determine whether a certain procedure is worthwhile. Obamacare in the insurance exchanges, the networks are very narrow now on those exchanges. That's all an example of government bureaucrats restricting care on the basis of cost. So this is a way in which government bureaucrats are very much the same as private industry bureaucrats. What separates private industry bureaucrats is that they are interested also in profit. So they have more options for making money than the government. They are able to seek profit. How do they pursue profit? Well, okay, they can control costs, but they can also generate more supply of care. And I think this is a crucial distinction between the public sector and the private sector. The public sector doesn't have that profit motive, which I think is so crucial to signaling the economy about where resources are most valued and needed.
Well, I gotta throw it back to Xavier. Xavier, that the ultimate goal, profit motive, is that what makes the business bureaucrats better than the government bureaucrats?
I mean, it doesn't make them better. It's their focus because they are, in most instances, obligated to seek profit for the company, but the profit for the company would more than often come at the cost of people. So I mean, the pre-existing conditions. It's not profitable for an insurance company to insure them because they have pre-existing conditions. So it's going to actually cost the insurance companies it's going to cost them profit compared to a regular person. Insurance companies want to insure the healthiest people possible because they're the least likely that they have to pay out for. And that's why in the past, before ACA, you had the pre-existing condition, or people with pre-existing conditions had to have catastrophic care.
Yeah.
So they were paying an arm and a leg to maintain some type of coverage so that they didn't go absolutely bankrupt when time came for their situation to get worse. But then again, in our current healthcare system, for a lot of plans, if you go past a certain limit, the insurance company will no longer pay. So somebody that has cancers or other things where it costs like $1 million just to get your cancer care, you could run out of insurance just because they're like, oh, you've met our like high cap that we're willing to pay out. So you could go bankrupt even if you have insurance.
So now, since we only have a couple more minutes, thank you to the audience for the questions. They were very informative and, kind of hurt my brain a little bit. This was actually pretty good stuff. So right now, end of the show. So what we got to do, our three panelists, this is what I like to call the elevator pitch. So now you have a short amount of time to explain to us why we should take your position leaving out of here. So now we're going to go. Let me start with Hawk Tai Champ because he just took the monster piss and now he's back. Hands are wet. He's shaking them right off. Give us the pitch. You've had the most time to think about it in solitude too, because you were in the bathroom. You were in an isolation chamber.
I swear
because you washed your hands, right?
On my screen, I took the time. That's why I was like, on my screen that says private chat, Nate. Not everything needs to be, but that's okay. Here's my pitch.
Go ahead.
If you think you're going to solve a very serious problem, like how we're going to fund healthcare so that there's quality of care, that the people who provide that care are being paid adequately, so it's an attractive and appealing venture for them to get into, you want to deal with these issues, then get serious about the facts. Get serious about making your beliefs comport with reality. If you want to argue this from some sort of phantasmagorical notion of, oh, I'm a cowboy from the Wild West, and freedom and socialism is theft, and you want to start going into what's this drag? You want to approach it from a social or political thing. You want to get into what's it called? Identity politics. Well, I'm a conservative, therefore I have to object to the very notion of $10 coming out of my pocket to save that child's life. That's my neighbor's child. Fuck that guy. He should pay for it. If that's how you want to approach a problem like healthcare, then for the love of God, step out of this conversation because you're not going to be able to address it. This is a complicated, difficult thing. How long is this elevator ride? Doctors are paid better. Healthcare outcomes are better in single payer systems, and fewer bankruptcies. Ding.
I don't hear anything.
I'm not hearing nothing. I'm going to keep going if he doesn't start unmuting.
Sorry, my mic was off. I just got off the elevator myself. So Hog Tie took us up to the 100th floor. So you got a couple of minutes, Brandon. So 5-minute elevator pitch. Why should we take your word for it? Let's go.
Well, I think a lot of people are taking a kind of a specious view on this issue where we're saying that things are expensive, therefore they're inaccessible. And I'm bringing in an economic perspective. The economics of healthcare is what determines our ability to distribute and allocate healthcare, our ability to provide healthcare resources in the quantities that are being demanded. I've given a couple of examples of exactly how that's true. Now, it's hard to compare apples to apples, but I think the one example that I gave that's as close as you can get to an apples to apples comparison is Medicare before and after price controls. Before, we had fewer drug shortages. After, we have more drug shortages. I also pointed out that in Canada, where we have a single payer healthcare system, which Hog Tie is saying is a true single payer healthcare system, we've seen that the shortages have or the waiting times have doubled over a 15-year period, doubled. So he's talking about, look at the results. I'm looking at the results, and there's a basis for the argument that I'm making in favor of a free market system that goes, it's founded in standard, uncontroversial principles of economics. And I think reality does bear that out, and the preponderance of evidence bears that out.
Thank you for that. And listen, I know Hogtie wants to get back in there, but I'm sorry, Hogtie, your pitch is over. We're now on to Xavier. So Xavier, you got to take us home. You got to take us home.
Right.
And you better not say that crazy. You would give us something good. So go ahead. 5 minutes. Hit it.
So I value human life over profits. So even if we're not somehow breaking even or less than the current costs, I think we should still move to a universal healthcare system because it covers every single person in the country 100%. That every single person should be able to go to a hospital and be able to survive and not have to worry about getting fired from their job and losing their health care, having people stuck there for life in a job that they don't want because they're worried about losing healthcare for their family. Wait times are way overestimated by Brandon, and the US on a lot of studies seems to come consistently behind countries with universal healthcare programs or government run healthcare programs. So we're losing in that fact. We don't get the best healthcare even though we're paying double the price of most comparable countries. So we seem to be the ones losing in this war of costs. Seem to be the one, like, we're staying stable currently, but we're still paying double the price of other countries. With inflation, it's going to keep getting worse and worse as times go on with our pricing, if we don't get control of it. And getting control of it would be a single payer system, because we are able to effectively manage the price by the people, because we can elect people to guide us in different directions. We cannot elect bureaucrats to decide how much our healthcare is going to cost and how much of a right we have for it.
Here we go. And as Xavier, I think I speak for Xavier when I say make America great again. Trump 2020, right? Right? That was the wrong guy?
Yeah.
I said the wrong guy. Oh, my God. The wrong guy. Well, listen, thank you guys for joining us tonight. This was a wonderful. I need to thank Brandon. Very, 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 very great points and a nice antagonist. Thank you to Xavier and Hogtie Champ for coming in and spending the night with us. And thank you to all our live viewers. You guys were great and you had some wonderful questions. My name is Nate Brody, host of the Magic Sandwich Show, and I want to thank again to my panelists. Again, we're not going to solve the healthcare problem tonight in this phone call, but there were a lot of good ideas, and no matter where you stand on the issue of how we're going to pay for it or what the best system is, I think we can all agree everyone should at least have healthcare should be available to everyone. And you can decide if it's a right or not, but if someone's sick, they should be able to go see a doctor and should have quality healthcare to take care of them and their family. And that's at a reasonable cost. And I think we all can agree with that. How we get there, obviously, is the detail. So my name is Nate Brody for Dragnut Silvers, Mr. Producer. You don't want to come up front. You got to do like Russell Simmons back in the day. You got to come on screen and show people you're back there. He says he has no clothes on. Well, who cares? Don't worry about it. All right. Next week. You want to come on camera next week, Mr. Producer. My name is Nate Brody for the Magic Sandwich Show for Hogtie Champ, Xavier, Brandon, and the Shirtless Man. We will see you next week. Peace. All right.